Hello everyone and welcome to our Provider Collaborative webinar. Today we're going to talk about Citizenship Waived Medical, also known as CWM, and give you some important program updates. We're going to start with a few introductions, give a brief overview of what CWM is, and then dig a little more into some of the additional services and billing guidance that we have for you now. We're going to round it out with a little more information about what we know about the MMIS update timeline and offer you resources. I will say that some of this content today is going to be very similar to our last CWM collaborative, and so we hope that this is useful and that it will start with the information we shared last time and then expand on it so you have even more at your disposal. So I wish we could do introductions all around, but we do have quite a few people on the line. So I'm gonna just introduce a few folks who are helping to run this show today. First off is me. My name is Jessica Diaz, she, her pronouns, and I am your provider outreach and engagement strategist. And I'm a member of the Community Partner Outreach Program. And I'm gonna allow Courtney to introduce herself next.
Good morning. Thank you for attending. My name is Courtney Seavey, she, her pronouns. I'm the Citizenship Waived Medical Program Analyst, and I work in the Medicaid Programs Unit. Thank you for attending today. And I'll pass it on to Christina.
And hello, everyone. I'm Christina Hernandez. I am one of the Regional Outreach Coordinators for Southern Oregon, and I'll just be here in the background monitoring any questions.
It's a very important part of this. Thank you so much for stepping in, Christina. All right, so we've done a quick round of introductions, and now let's talk CWM. All right, so CWM, Citizenship Waived Medical, is a type of Medicaid benefit. At this point, we should, in Oregon, only be seeing it for adults aged 26 to 54. And this is folks who are living in Oregon and do not have a qualifying non-citizen status. CWM is emergency services and a few more things that we'll talk about. And I do want to make two specific notes for us, which is that you may have seen in the past it spelled out CWM, which is a different acronym with some slightly problematic language that we've moved past. So I'm not even going to explain what that old acronym says. But just know if you see a document or a resource that has it spelled out slightly differently, it's the same program. We've just moved to a new streamlined acronym. It's pronounced the same. We call it CWM. We like a lot of acronyms, so pardon us on that. And if you find a resource that you are actively using that still has that old spelling or even maybe calls out that older acronym, please let us know, because we're trying to do a refresh of all of our materials and all of our systems. And I believe you should also be seeing CWM now in the provider portal or MMIS instead of that older acronym. So that is an update versus the last time we were talking to you all. And we're continuing to work on that. There's many, many documents and websites and whatnot to update. So we're working on that actively. I do also want to call out that today we're talking about CWM. There is another program called CWM Plus, which is full OHP benefits during a pregnancy and for the 2 months after a pregnancy ends. And we're going to be not talking details of CWM Plus beyond what I just shared. So if you have questions about CWM Plus, feel free to put them in the chat. We may get around to it outside of this presentation today. And we are focusing on the CWM programs that are not related to that plus level of benefits. And I alluded to it in my last slide, but I want to call it out, which is that CWM has changed in part because of a program called Healthier Oregon that was launched July 1 of 2022. In the past, people 19 to 25 years old and 55 and older without an eligible non-citizen status, or also known as immigration status, they had emergency-only CWM care. And now we are able to offer full OHP benefits regardless of immigration status to more people than ever before. And that is anyone who was 19 to 25 or 55 and older who was already on CWM before the program launched, and then folks who have not engaged with our systems can apply and go directly into Healthier Oregon. There's no CWM waiting period or anything like that. So if you see anyone who's between the ages of, well, actually under 26, so 0 to 25, because there's also coverage for children regardless of immigration status, or if you see someone who's 55 and older who is persisting on CWM level membership, that could also be a great opportunity to engage our state folks and get that resolved. You should only see CWM individuals who are 26 to 54 at this time. So that's our quick explanation of CWM as a program and how it interacts with our Healthier Oregon program. We've had a lot of exciting things happening with the CWM program, and there are a few that went into place January 1st of this year of 2022 that we're going to talk more about today. So this is where we're going to be spending most of our time, and I'm going to introduce it and then hand it over to Courtney. So the additions that we are now covering within CWM includes end-stage renal disease, behavioral health crisis, and cancer care. These also introduce, for the first time, some implications for pharmacy and the CWM level benefit. So we do have a note overarching the CWM program is that if someone has pharmacy needs that are included in these new sets of definitions, a prior authorization is required in order to get those medications. Another thing that we'll be talking more about, but I want to be upfront about right at the beginning here, is that this involves a lot of complicated system updates, and they are still very much in progress, and we're going to call out which pieces are in progress, a few pieces that are completed, and I think talk in broad terms about what we hope is our timeline. Although if you attended our last one, you will notice that timelines are not always as reliable as we'd hope. So we have been, and I would say we, but Courtney's been doing a ton of work on getting these updates into place. And so some of the original timelines we gave you have changed, and we'll call that out as well. And with that said, I'm going to hand it over to the expert. Courtney, take it away.
Thank you, Jessica, for the introduction to the citizenship waived medical benefits. I will start out with end-stage renal disease. This is a benefit that is functioning in MMIS. CWM members have been eligible for emergency and inpatient dialysis treatment since 2021. Included this year is outpatient dialysis. So as of January 1st, CWM members are eligible to receive outpatient dialysis, and the goal of this coverage was to increase continuity of care for our CWM members, allow CWM members to schedule appointments, and increase the availability of service and providers. CWM members can access outpatient dialysis clinics to receive care, and this is fully functional in MMIS. Unfortunately, at this time, drugs for comorbid conditions are not included with our end-stage renal disease benefits for emergency CWM benefit level. Immunosuppressant medications post-kidney transplant is another benefit that has been available to CWM members since the beginning of this year. I am working with KeyPro for care coordination for members post-kidney transplant to support access to receive specialty office visits and labs to monitor medications. There's a link here in this slide for OHP care coordination program. Additionally, the pharmacy team is working in conjunction with our KeyPro care coordination providers. If they find a member that has received a prior authorization for an immunosuppressant medication, they are alerting our KeyPro care coordinators so that we have sort of a back and forth care coordination process between KeyPro and pharmacy to make sure that we are capturing members that need these medications. What is covered for members that need immunosuppressant medications post-kidney transplant is non-emergency office visits and labs. These diagnoses will be in code group 6186 and will be considered an emergency without the requirement of the emergency indicator. Behavioral health crisis benefits have been eligible to CWM members since the first of this year. Behavioral health crisis is defined in Oregon Administrative Rule listed here in this slide. The behavioral health crisis is actual or perceived urgent or emergent situation. Individual stability or function is adequately disrupted and immediate care need to resolve to present serious deterioration, referral to a significantly high level of care or death. Behavioral health crisis coverage includes crisis counseling, medications to stabilize the crisis, which do require a prior authorization. Medication coverage includes a 30-day supply with one refill if indicated by the provider on the prior authorization at the time of the crisis episode. Behavioral health codes will be included in group 6179. This following is a slight change in the reason for this webinar in our billing policy and billing guide. Professional claims must use procedure codes 90839 or 90840 to identify the claim as a crisis. Inpatient and outpatient claims must use the emergency admit type. In policy and previous billing guide, inpatient and outpatient claims, all claims for a crisis required the procedure codes. At this time, only professional claims will require those procedure codes. Inpatient and outpatient claims will use an emergency admit type to pay. At this time, CWM crisis benefits are limited to licensed behavioral health care or healthcare providers. This benefit does not include ongoing behavioral health treatment. And again, unfortunately, this is not yet fully functional in MMIS. I will update the Provider Matters bulletin as I get closer to implementation of this benefit. Medications are currently available. Thank you. The behavioral health crisis pharmacy. So pharmacy benefits have been available to CWM members since July. The pharmacy team has been very helpful in setting up this benefit and getting this benefit live. Prescribing providers must write on the prescription that is prescribed in conjunction with a crisis visit, include the diagnosis on the prescription, and call for prior authorization. Pharmacy providers can call the pharmacy call center for a one-time override at the number listed here on this slide. The pharmacy team is very aware that the prior authorization process can add some time to as a barrier to accessing medication, and we really want providers to understand that the prior authorization is required and to work with the pharmacy team to get that prior authorization ideally before the person leaves your care, so that there is not a wait time at the pharmacy for that prior authorization. So sort of in the perfect world, we want to facilitate access to pharmacy benefits for a person in crisis. Cancer treatment. This was another change that prompted this webinar. In reviewing the policy and billing guide, and speaking with several very intelligent people on our team here at HSD, I found that the policy and billing was very confusing and really wanted to streamline this section so that providers and patients received care with the intent to cover cancer treatment, side effects, comorbid conditions, and complications of cancer treatment that, when if left untreated, would place the patient's health in serious jeopardy, cause serious impairment to bodily functions, or serious dysfunction to any bodily organ or part. Cancer treatment includes surgery, lab tests and radiology to measure and track treatment, oncology office visits, inpatient treatment and recovery, and medications to treat cancer, side effects of cancer treatment, comorbid conditions and complications. The changes to billing include streamlining the billing policy and provider billing guide. Any claim with a cancer diagnosis from Group 6186 can be electronically submitted. Cancer claims do not require an emergency indicator to pay for CWM. The cancer diagnosis is considered the emergency. At this time, cancer is not fully functioning in MMIS. I anticipate this benefit to be functioning mid to late January, early February. And I do apologize for the vagueness in that timeline. As Jessica stated in the beginning of this presentation, there are a lot of moving pieces to this and a lot of people working very diligently to make this benefit work for CWM. Cancer treatment pharmacy. Again, the pharmacy benefits for CWM members have been available since July 1st. So if a provider is treating a patient for cancer, medications are available. The provider will need to request prior authorization for each drug prescribed, include the cancer diagnosis on the prescription. For some drugs, chart notes may be required to show treatment meets clinical prior authorization criteria. Pharmacy and CWM. If the prescription is for a non-covered condition, the pharmacy should notify the patient that the drug is not covered by their Medicaid plan. A covered condition or diagnosis is unknown, pharmacy should notify the provider that a PA is required. A behavioral health drug prescribed as part of an emergency visit or in conjunction with a crisis episode, pharmacy should call the pharmacy call center for an override. Number listed in this slide. Prior authorization requests. Providers can submit prior authorization requests in 3 ways. Call the Oregon Pharmacy Call Center, submit via secure provider web portal, or fax. All PA requests should document diagnosis for behavioral health condition, a recent crisis emergency visit for the diagnosis. For some drugs with clinical prior authorization criteria, chart notes should also be submitted. MMIS updates coming soon. When this work is complete, we will let you know and update the list of CWM emergency diagnoses codes. There are new diagnoses codes, which we have on another slide, that we will be listing separately on the CWM website. In the meantime, for behavioral health and cancer treatment, please wait to bill for these services until the codes are added to MMIS as covered CWM emergency codes. If you choose to bill these services earlier, OHA will deny the claims, then reprocess them. Use procedure codes for professional claims for behavioral health crisis treatment, listed here in this slide. Please utilize provider services for questions. Members can utilize client services. Provider Matters newsletter is the best place to keep up to date on additional updates and changes. Please sign up to see past editions here and to get alerts for current updates. Here are the diagnoses codes groups for CWM. 6014 includes emergency diagnoses. These are currently listed on the CWM website. Diagnoses in group 6014 require an emergency indicator to pay for professional, inpatient, and outpatient claims. These conditions are considered always an emergency when indicated so on claims. Group 6149 are CWM non-emergency diagnosis for labor and delivery, reproductive health, and COVID diagnoses. These diagnoses do not require an emergency indicator to pay, they are now listed on the CWM website. Group 6179, CWM Emergency Behavioral Health Crises Diagnosis, will be posted on the CWM website when they are functioning in MMIS. Group 6186, Cancer Diagnoses and Immunosuppressant office visit codes will be updated on the CWM website. Group 6186 does not require emergency indicator on claims. The cancer diagnoses or the immunosuppressant office visit code are the emergency for that code group. CWM resources, the CWM policy website will include all CWM updates and billing guide, which is currently updated to reflect the new changes discussed here. CWM member fact sheets currently in English and Spanish. There are other languages we are in the process of translating these fact sheets into, and will be posted on the CWM policy website. CWM billing guide is linked here, and new code updates will be coming as soon as we have those live.
Courtney, I have a statement / question. We'll see how I phrase it as it's coming out of my mouth. But related to the CWM billing guide, do I understand correctly that it is in the, well, I think a lot of these details are already in it, but there's also an update being planned that will be out very soon. Is that correct?
Yes, I did not check before we started. We have a great person that helps me with the website who's extremely efficient. I believe that if they're not currently live, consistent with what we just spoke about today, that they will be by the end of the week.
Perfect. So the same link will always lead you to the most up-to-date version of this guide, which is why we have put these links directly into the slide, and we'll make sure that those are available to you all as well. But just know that as we continue to build things out, we are continuing to update the resources that we're making and the resources that are on this list. And I think with that, we have gotten through our content today. We wanted to leave plenty of time for Q&A and to see what information we can maybe answer today or bring back to you based on the feedback that we're getting today, and then go staff it with the other movers and shakers within the agency. And I do see a few questions in the chat already, so maybe I will start with those, and please feel free to continue using the question box, and we will we'll see how many questions we can answer and address. All right, so the first question is, what is a comorbid condition when it comes to cancer treatment? And I'm going to pass that over to Courtney, if that's all right with you.
Yeah, thank you. So a comorbid condition would be any condition that places the patient's health in serious jeopardy. Jessica, if you're able to backtrack to that cancer slide, that could be helpful to have a visual. That helps me. And really leaving the decision up to the oncologists and the treatment professionals here to determine if a comorbid condition, if left untreated, would place the patient's health in serious jeopardy, cause serious impairment to bodily functions or serious dysfunction to any bodily organ or part in relation to the person's cancer treatment. So we want to make sure that any other health impairment that could be occurring at the same time as the person's cancer that could impact the person's cancer treatment is treated as well. So it's pretty open in terms of what that comorbid condition could be.
Thank you. And then I'm just going to ask for confirmation in the question box if that answered your question or brought up any new questions for any folks. And then I have another question. I think we can do a little bit of explanation about why these different code groups and programs are fully operational in MMIS, and the partner has asked why they are being suspended, but I believe they are not suspended so much as we are making them. And so we are having to put new information into the systems, but I'm sure Courtney can say that more eloquently than I just did.
So some CWM claims are being suspended because of an expanded emergency services project that we're working on to support paying emergency claims on admit rather than just final diagnoses. So there are some claims that are suspending in MMIS to be manually processed. So if you're seeing some claims that are being submitted suspended, we have a team of really amazing folks in claims that are looking over those and paying according to the logic that is listed here in these slides.
Oh, I definitely did not fully understand that question. Thank you so much.
Mm-hmm.
And that is something I do want to call out. We didn't include it in the slides today, but there is also that expanded definition of what an emergency is that we've been able to operationalize. And so there are new implications for some of the other sort of more traditional CWM covered uh, situations as well, because it used to be that the final diagnosis had to fall into the category of an emergency, and now we can rely on admit codes as well. So I do want to call that out, even though we don't have a slide for it, because it is important. And then I do have a follow-up. Oh, go ahead.
Nope, that's what I was going to say. I'm like, there is a follow-up to that question saying, do we know about when the timeline for those to be processed, for those claims that were suspended?
No, I'm sorry, I don't have a better answer for that. So like I was saying earlier, there is a team of amazing folks that are working on manually processing those claims and staying on top of our agency timelines, which I don't have precisely memorized, but working to stay on top of our agency timelines for claims processing. Unfortunately, the manual team is not quite as efficient as our automated processes, so there are some delays that are occurring. So yes, I can't fully answer that, but we are staying on top of agency timelines to process suspended claims.
And shield your eyes, everyone. I'm going to pop us back to the end of the presentation really quick. And we have a few questions that I can answer in part. But they are more relating to what are eligibility pieces to this, which is something that maybe we can tackle more outside of this presentation, but and also some questions around public charge. And I can go hunting for our most recent public charge resources, but I won't be able to do that until after we're out of this presentation. So just know that we do have public charge resources in multiple languages. Off the top of my head, I cannot remember the exact date of when they last got updated, but I believe it was in this calendar year. So yes, we can get that to you all. And I'm also seeing a request for us to actively email this PowerPoint presentation to the folks who are in attendance. And so that might be a great opportunity for us to also send along those public charge resources. So noted, and yes, let's do that. So really quickly around being a qualifying versus non-qualifying non-citizen when it comes to Medicaid and OHP rules. I'll give an example of a qualifying status and then an example of a non-qualifying status. So due to Medicaid rules, if someone has lawful permanent residency, also known as a green card, and they have had that status for over 5 years, then that becomes one example of a qualifying non-citizen status. Another example of qualifying non-citizen status, if someone is a member of the Compact of Free Association, so a COFA resident, does not have to be a US citizen in order to qualify for full OHP benefits. Now, a non-qualifying non-citizen status, and we are trying to move towards non-citizen instead of immigration, so you'll hear that in my language. For instance, a DACA recipient is not a qualifying status when it comes to Medicaid rules. We do have the Healthier Oregon program, which opens up for certain age groups and may expand over the next year. More news on that in other venues. But is traditionally not a qualifying status when it comes to the laws and rules and regulations. And when people ask me, like, why are these specific lines drawn in the sand? And that's just because that's what the laws and the rules say, and they can change. And we've seen them change with things like our Healthier Oregon program. So I hope that really quick and not fully adequate primer on the difference between a qualifying versus not qualifying status is. I hope that was useful. And now that I've sort of gone off the track of our topic today, I do see that we have a question that is fully on topic. Thank you, Rebecca. Which is, and let me go to the code groups again. I think just for clarity over when an emergency indicator is required and when it isn't. And I'll hand that to Courtney.
Thanks, Jessica. And it's a good question, Rebecca. Thank you for asking that. So there are quite a few changes occurring with CWM. Traditionally, Group 6014, it was the only diagnoses code that was transparent and listed for CWM. It's our emergency diagnosis code, and this code has historically and will continue to require an emergency indicator for any diagnoses in that code group. So if a member is receiving care for an emergency situation, the emergency is listed in this code group, the claim needs to be marked as an emergency.
Okay, so that is confirmation that code group 6014 does require an emergency indicator.
Yes.
And then I have perhaps what is more of a soapbox than a question, which is, I think for me, what has become very clear from the large amount of work, high level of complexity of getting these new pieces of CWM fully operational is that a big part of this is making sure that providers and our community partners and our members know about it. And so I think my big ask for the folks in this room is help us get the word out about these changes. It's really important for people to know that they have options in places where maybe this time last year they did not have coverage that would help them with their cancer treatment, with their behavioral health crises, things like that. And so as we continue to refine the systems and the back end, the really important human component is really something that you need to be out in community. You need to be in provider offices to really be making that difference. And so having open communication also between prescribing providers and pharmacy, open communication with provider services if there are things that you aren't sure about or want more information, and open communication with us here, Courtney and myself and other folks within OHA about what you need to have success with this. So that's my I guess, yeah, where I get passionate is we want to know what you need. And I know a big part of this is we need the systems to be fully up and running. And yes, noted, and we're working on it. But are there other things that you need in order to feel confident about what is and isn't covered under CWM and how to help people get what they are eligible for and access the care that they have? Because that is ultimately where we have success or not. I'm honestly getting a little emotional and I didn't mean to do that, but I do think it's really important that as we talk about some of the, more technical aspects, we don't lose sight of the human aspects as well, which is that there are folks who are receiving life-saving care that they were not able to get before. But I also know that there are plenty of folks who don't even know this is an option. And the complications with billing are not helping, but we are committed to putting in the time and effort. So please don't be shy. Reach out to your ROC. regional outreach coordinator, and they can help direct you to folks who can really move the dial when it comes to these sorts of situations. And we do want to put in the time and effort. Okay, I had to say that. And we're actually running well ahead of schedule. Are there any other questions or concerns or thoughts that anyone has that they want to make sure we talk over today? I see a question / comment about some concerns with claims. And I'm going to read this as it is, and Courtney, and then I'm going to hand it over to you, which is admission type for claim submission or when reprocessing for cancer. This provider has been appealing all of the claims due to them not always being emergency, and they are denying. And I wonder if that has to do with the fact that some of the cancer pieces aren't fully in the systems and we just have to wait, but I'm going to hand it over to you, Courtney.
Thank you, Jessica. Judy, I would like to get more information on the claim to be able to answer that question. I'm not sure why they're denying on appeal when our claims folks in appeal have questions about claims denying that they feel like by policy should be paying. They do come to me. So we have a really good line of communication there. So yes, I would like to know more about that. And my email address, I think it is available here, so that I can learn more about what's going on in these claims and look into that.
And yes, absolutely. That's actually a good reminder too, which is at this point, there are so many complex details that it really does help for us to have as much of the specific information as possible, and we can chase that. And oof, I think your contact information is way at the beginning. So pardon me again, I'm going to quickly jot through.
I don't think it's there, but I can put it in the chat for everybody.
I'm going to jump back to where I was because I think it's just our names. You're right. And I'd also say that at this point, when in doubt, your rocks can also help you find the right internal person. If it relates to CWM, that there's a good likelihood that Courtney is going to be involved. But also always feel free to involve your rock as well. CPOP is excited to help. And actually, that might bring me to my final topic, which is not in the slides, but does relate, because normally I would tell you all to send things my way. And the reason I'm not today is because this is my last week with the Community Partner Outreach Program, and I am rotating into a new position within OHA starting next Monday. So just as a heads up, all of you, if you are sending things to me, Jessica Diaz, I will still absolutely make sure that they get to the right place. But just know that in a few weeks, there will be a new provider strategist and they'll be introducing themselves to you. And I'm sure it's all going to be awesome because we have a lot of awesome people doing this work, but that it might not be me. So I normally am very upfront about, hey, send everything my way. And the reason I am not is because we're in a moment of transition right now at CPOP. So I just wanted to give a little bit of airspace to that as well. And that also might be why I'm getting more sentimental today than I normally would, because you all are such a fantastic network of folks. And it's hard to say goodbye, but I am sneaking my own personal update into this collaborative meeting, and I hope that's okay. So it has been such an honor working with you all, and I'm sure that some of you will hear from me in my new role as well. But just know that the Community Partner Outreach Program is committed to making sure that providers are supported throughout all of these changes, and that you can always go to your regional outreach coordinators. And there's also the community.outreach generic inbox. So if you're ever truly not sure who to turn to within CPOP, we will direct you to the right person. And exciting things in 2023, and you'll have new folks supporting you, and it's going to be awesome. So I think that's about it. I think that's what we came here to do today. Thank you all for joining us. I think we were up to about 50 folks. And just know that there are more resources coming. We will send a follow-up email. I'm committing to doing that. We'll also look for those public charge resources. And please continue to send to Courtney or to a member of CPOP any specific examples where people are having trouble access, are getting bills they shouldn't, or are otherwise experiencing things with their CWM coverage that are different from what we've outlined for you today. You are such an important part of this work, and we really hope that you continue to engage with us and have a great new year. And thank you so much, Courtney and Christina, for bringing us this content and helping with logistics, and really overall being very passionate and wonderful human beings. Thank you all so much for joining. I'm going to stick around and keep an eye on the question box for a little bit, but we are convened, and I'm going to mute myself.